welcome everyone. Happy New Year. I'm Verity. I'm a research fellow at Cardiff University, and I'm going to be chairing this session. So thanks so much to everyone for joining. We've got a really brilliant turnout, 37 people and climbing. Thank you so much for joining this ExChange Spotlight webinar. I'm absolutely delighted that we've got Dr. Sarah Thompson joining us today from Cascade. Sarah is a colleague of mine. I work at Cascade and also at Scale, which is a new research centre for social care and AI research. Sarah's going to talk for about 40 minutes. About her recent research into experiences and outcomes of autistic children in foster care in Wales. And I will hand it over to you now, Sarah, to get started. Welcome, and thank you so much for taking the time to share your research with us.
Right, thank you very much. Yes, like Verity said, I'm going to talk to you about some research I've done on the experiences and outcomes of autistic children in foster and kinship care in Wales. So if we move on to the second slide. So just a little bit about me. Like Verity said, I'm a researcher in Cascade, and I've been here since 2019. I've done previous work as a support worker in children's social care and previous research work in psychology and in education as well. And my current research interests are in neurodivergence and children's social care. So we move on to the next slide. This is the project I'm going to talk about today. So this is a Health and Care Research Wales funded project from 2021 to 2025. It was about a 3.5-year research project looking at the experiences and outcomes of autistic children in care. And this project was informed by lots of different stakeholders who helped to really shape the research. This is by social workers, foster carers, charities and organisations, and care experienced young people as well. So we move on to the next slide. So why did I focus in on this group of young people? So children in care we know are more likely to be neurodivergent than their peers, but there is actually little research, especially when I started this, around the numbers of children in care who are neurodivergent. There was one study that found around 3% of looked after children in England had a diagnosis of autism, but it was thought this was probably an underestimation. And this group's an important group to kind of consider because both groups independently, so children in care and autistic children, are linked to an increased chance of poorer outcomes into adulthood. So things like lower educational achievements and an increased risk chance of mental health difficulties. But really little has been done on the group, the overlap group, so those who are autistic and care experienced, and we know really little about their risks and outcomes. So it was important to learn more about them. So moving on to the next slide around gaining an autism diagnosis. So this was getting an autism diagnosis is something that's often seen as a benefit, but just to mention at the start that this isn't something that everyone wants or needs, and some people don't want an autism diagnosis, don't require one, don't think it's necessary for them, which is absolutely fine. But there are some benefits of getting an autism diagnosis that have been shown through the previous research. So for example, early identification is often seen as one of the best ways of meeting a child's needs. So understanding early on to be able to get things like speech and language therapy or school support in place is often seen as one of the most beneficial ways to support young children. There are also benefits in adulthood. So things like an increased self-understanding and belonging, and sometimes like protections in the workplace as well can come from having this diagnosis. There's also quite a strongly held belief that a diagnosis leads to more support, but I've put numerous question marks here because that's actually not always the case and can sometimes lead to some disappointment if this isn't the case. So we can clearly see there are some benefits to some people obtaining an autism diagnosis if this is suitable for them, but obtaining this diagnosis is challenging. And it's challenging in general. There are really long waiting lists that are really well known about. But there seems to be some extra challenges for those in care that have been started to be outlined in the literature. So the social communication difficulties of autism can sometimes be misclassified as trauma or attachment disorder. So there's a lot of overlaps in the behavioural presentation of autism and attachment disorder or trauma. And although it's possible to have a diagnosis of autism and attachment disorder together, sometimes these subtle differences can be really hard to identify and tease apart to work out the most suitable diagnosis. So more research is needed to clarify this overlap and therefore ensure suitable diagnosis and support. So that leads on to this project that I completed on the next slide. So the overall aim of the project was to understand more about autistic children in care, both diagnosed and undiagnosed, focusing on prevalence and patterns of diagnosis, levels of autistic traits, and experiences of these children related to their diagnosis and support needs. And I tried to address this aim in 3 different parts. So I did a population level analysis that looked at rates, patterns, and outcomes for autistic children in care. This is using the SAIL data bank. I did a survey of foster and kinship carers to identify autistic trait patterns and current difficulties. And finally, I did some qualitative research to understand the diagnostic process and support available. So what I'm going to do for the rest of the talk is go through each of these 3 parts in more detail and tell you what I did and some of the key findings. So if we move on to the next slide, we're going to look at part 1. This is the administrative data. This is the population level analysis to look at rates, patterns, and outcomes for autistic children in care in Wales. And this had 3 main aims. So firstly, to establish the rates of autism diagnosis for children in care in Wales compared to those without care experience. Secondly, I wanted to profile the patterns of diagnosis, so specifically looking at the age of diagnosis for those in care compared to those not. And then I wanted to compare the educational achievements and any mental health diagnoses of care experienced autistic adults to care experienced adults who didn't have an autism diagnosis, and then autistic adults that didn't have care experience. So we're going to look at those 3 different groups. So we move on to the next slide. This is going to show the method that we used. So I used the SAIL data bank for this, as I mentioned on one of the earlier slides. So SAIL is a great resource that contains billions of anonymised person-based records about the population in Wales. And this enables us to do data linkage to compare lots of different issues. And in the case of my research, this is around health, social care, education, etc. On the right here, we've got a list of the databases I used to do the data linkage. But also at this point, I just want to mention there are some limitations with the data that it's important to be aware of. Because of the rules around what data I can extract from SAIL and what data I can present to you, all of the percentages are presented to the nearest whole number. All of the counts of people are rounded to the nearest 5. And some data has to be suppressed if there's not enough data there to ensure anonymity, which will happen with one of the findings I showed to you. So just be aware that there's some of these rounding things going on when I present the data. Okay, so if we move on to the next slide, for the SAIL analysis, I had to do the analysis using 2 different cohorts, 2 different populations. So cohort 1, that I'm going to talk about now, was used to look at the rates of diagnosis and the age of diagnosis. So this cohort consisted of young people with care experience that are in the database between 2002 and 2022, and this was around 17,000 young people. And I also had a matched control group. So this was a group with no care experience that were matched to the group with care experience based on the levels of deprivation, the week of birth, and sex assigned at birth. And we had 3 of these matched control group people per young person with care experience. This resulted in around 51,500 people for this group. So we move on to the next slide and we can start looking at some of the results. Firstly, looking at the levels of autism diagnosis, comparing these 2 groups. So there was 7% of the care experience group had a diagnosis of autism recorded in the SAIL records, compared to 3% with no care experience. So this was a significant difference. So it was significantly more children with care experience had an autism diagnosis compared to those without care experience. I also looked at the average age of diagnosis, and this was also significantly higher for children with care experience compared to those without care experience. So it seems just by looking at this that children with care experience are more likely to get a diagnosis of autism, and it's more likely to be slightly later than those without care experience. So we move on to the next slide. what I did then was I wanted to know more about the age of diagnosis. So the data presented on this slide is just the children and young people who had a diagnosis at some point in the data. So all of these had a diagnosis at some point. And then I wanted to compare the percentage diagnosed by these different age points. The age points chosen based on school ages, so 7, 11, 16, 18, and then after 18. So the ones that are highlighted in grey are the ones that there was a significant difference in. So there wasn't a significant difference between the number of autistic care experienced and non-care experienced children diagnosed by age 7 or age 11. The numbers were quite similar. But then into the teenage years, the differences start to emerge. So you were significantly more likely to get your diagnosis of autism by age 16 if you were not care experienced compared to if you were care experienced. And the same pattern at 18. And then subsequently, if you were care experienced, you were more likely to get your diagnosis into adulthood if you had one. So if we think back to some of the earlier stuff around the support, obviously this early diagnosis was seen as important for getting support. And some of these people are getting their diagnosis a lot later into adulthood, which could have knock-on effects on support, their identity, workplace protections, and things like that. So if we move on to the next slide and we'll look at cohort 2. So this was looking at the educational outcomes and mental health diagnoses into adulthood. So to look at this, we used individuals who turned 18 in the database between 2002 and 2022. So we're looking at adults. And we divided this into 3 groups. So these 3 groups aren't matched like the last one. This is just the data that was available. So it's important to be aware of that. So group 1 was a group with both care experience and a diagnosis of autism. Group 2 was without care experience but did have a diagnosis of autism. And group 3 was care experience with no diagnosis of autism. You can see by the numbers in each group, there is quite a lot of variety. Obviously, group 1 is going to have the smallest population size there. It's also important to just be aware at this point that a diagnosis of autism in the database, if you don't have it, it doesn't mean necessarily these people are not autistic. It might not have been recorded or they might not yet have their diagnosis. So it's important to be aware of that, but this is the data we have available. So if we move on to the next slide, we can see the start of some of the outcomes and some of the results of this. So firstly, looking at education, I wanted to look at GCSE results, sixth form attendance, and higher education attendance. So if we look at GCSE results first, this is presented by a Q-point score, which is the measure that was available in SAIL. And this is basically a combined measure of the 8 best GCSE results. So a higher number here is a higher GCSE score in the top 8 results. So if we look just at this one first, we can see the ones highlighted in the dark grey are the significantly highest number. If there's a light grey, it's kind of the significantly middle, and then the white is significantly lowest. So if we look at GCSE scores, the group with autism only, so no care experience, scored significantly highest in their GCSE scores. Then the group with care experience only, no autism diagnosis, was significantly lower than that. But they were also both significantly higher than those with both autism and care experience. So those with autism and care experience, overall, we're getting on average lower GCSE scores than the other 2 groups. We move on and look at sixth form attendance. Those with autism only had the highest rates of sixth form attendance, with both of the care experience groups scoring significantly lower. And then if we move on to higher education attendance, so with this group, again, the autism only group was scoring significantly highest, with the care experience only group behind that, and then significantly lowest was the autism and care experienced group. And there's a star into the percentage here because I said before about the data suppression, but it was the significantly smallest group. So across the board with this, the autism and care experience group do seem to have some of the poorer educational outcomes that we suspected. So we move on to the next slide. This looks at mental health diagnoses. And again, splitting it up across the 3 different groups and looking at anxiety and depression. There are some differences here, but I actually think the really key takeaway message is how high some of these percentages are to have a diagnosis of anxiety and depression. It's likely that not everyone's diagnosed or it's not all recorded, so these numbers might be even higher. If we compare some of these numbers to the World Health Organization figures, there are around 4% for anxiety and about 3.6% for depression. So these numbers, I think the takeaway message here is these numbers are just quite large across the board, and that's just something we really should be aware of. Okay, I'm going to move on to look at the survey of foster carers on the next slide now. So this was a national survey of carers to identify autistic trait patterns and current difficulties. And it had two main aims. Firstly, to discover the levels of autistic traits of children currently in care. And secondly, to investigate the associations between autistic traits and attachment problems in the daily lives of children. So here we've kind of moved on to look at the traits and behaviours rather than just diagnoses, to hopefully look a lot more at the intricacies that are happening here. To move on to the next slide, we can look at the method. And so this was a survey that I designed and distributed using Qualtrics. It was emailed out to foster carers via the fostering network. They had 840 carers on the email list that was sent out to those carers twice. And it also did a paper mail out to 3,200 foster families in Wales. So within this survey, I asked lots of different information, which I'm not going to get a chance to go through all of it today, but just to give you an idea of what was in there. So there's the background information. So we've got child demographic information, child placement history, child diagnostic information, and information on the foster carer home. And we also had a set of standardized psychological questionnaire measures. So we had a social communication questionnaire as a measure of autistic traits, the relationship problems questionnaire as a measure of attachment disorder, strengths and difficulties questionnaire as a measure of general difficulties in a child's daily life, and the parental stress scale. So I'm not going to look at all of these because I could have done a whole 45-minute talk, I think, just looking at all of this data. But to give you an idea, we're going to focus in on two of these questionnaires. So we move on to the next slide. The first one is the social communication questionnaire. So this is used as a screening tool for autism. It's not a diagnostic tool, but it gives an idea of traits and difficulties. It's a 40-item questionnaire with yes/no questions throughout. Importantly, we use the current version of this questionnaire. There's two versions, a current version and a lifetime version. And the current version focuses on behaviours over the last 3 months only. The lifetime version focuses on recent behaviours, but also younger childhood behaviours. The lifetime version is more robust, but obviously foster carers might not have that information, and they might not have information about the child when they were younger. So the current version was the best version to be used with this population. It's also given to children aged 4+, so it was only presented to carers who answered the questionnaire about a child aged 4+. There were 3 subscales as well within this questionnaire, which I will touch back on again later. And these were reciprocal social interaction. So this is difficulties with social understanding, sharing interests, and back and forth social engagement. There's language and communication, which is understanding language, using language for social purposes and general communication skills. And then restricted repetitive behaviours, which is things like repetitive motor movements, want or need for sameness, restricted interests, and unusual sensory responses. So just to give you an idea of some of the sorts of questions in this 40-item measure, on the right here, we've got, does she or he ever use odd phrases or say the same thing over and over in almost exactly the same way? Does she or he ever use socially inappropriate questions or statements? And does she or he ever seem to be more interested in parts of a toy or an object, e.g. spinning the wheels of the car, rather than using the object as intended? So there's 40 questions kind of along this style. So if we move on to the next slide, this is the relationship problems questionnaire. This is a measure of reactive attachment disorder. It's a 10-item measure presented to carers who are answering this for children aged 5+, because that was the age for this questionnaire. And they were presented with statements and had to say whether this was exactly like my child, a bit like my child, or not at all like my child. And again, there was subscales. So there was 2 subscales for this one. The first was inhibited behaviour. So this included things like being withdrawn or lack seeking comfort. and disinhibited behaviour, which included indiscriminate friendliness and seeking comfort from strangers. And again, on the right-hand side here, we've got some examples of the statements from this measure. So it included things like gets too physically close to strangers, often asks very personal questions, even though she or he does not mean to be rude, or can be aggressive towards him or herself. So they had to say how much that was like their child, and there was 10 of those statements. So we move on to the next slide, and this is the results. So the sample size for this was 241 children after we'd removed those that weren't high quality data. The age range was from about 1 up to just below 18 with a mean age of 10. So we had a wide range of ages. We had 56% of the sample were male, around 78% were in foster care, with around 19% in kinship care with a special guardianship order, and the remainder being in other sorts of placements. And we also had a huge variety of placement lengths as well, which varied from a few days up to 14 years. So on the bottom half of this slide, we've got some information on diagnosis. I asked about lots of different conditions, but again, I'm just going to focus in on the autism and attachment disorder for this. For each condition, I asked whether they had a diagnosis, but I also asked whether they were awaiting or undergoing an assessment. They didn't have a diagnosis, but it was suspected, as well as the yes and no responses, just to kind of capture a broader range of information here. So for autism, we had around 7% saying yes, the child had a diagnosis. And this is the same percentage we got in the SAIL data bank for those with care experience. But we also had a further 8% and 9% that are either awaiting or undergoing an assessment or suspected of being autistic. These are quite high numbers all put together. Also for attachment disorder, we had around 13% with a diagnosis and then about 2.5% awaiting and around 13% suspected of having attachment disorder. So if we move on to the next slide, we can look at some of these questionnaires. So this is focusing in on the traits, the behaviours, rather than the diagnoses. So firstly, we've got the social communication questionnaire. We have data for 189 children here. So for this measure, a score above 15 suggests a likelihood of autism. It doesn't mean they're autistic, it's not a diagnostic tool, but usually a score above 15 would suggest an increased likelihood and that further assessment or investigation should be undertaken for anyone that scores at this level. And in my sample, that was 141 children, 75% of the sample, which is obviously a really large number. And this is compared to the 50 children on the previous slide who had a diagnosis, were undergoing diagnosis or suspected of being autistic. So obviously this is a really high number. It's not saying that 141 of these children are autistic, but 141 of these children are displaying high levels of autistic traits, and that perhaps needs some more investigation. If we move on to the next slide, this is similar data for the relationship problems questionnaire. So this is the measure of reactive attachment disorder. We had 144 children included in this. And for this, a score of 7 or over is deemed as what's called a likely case. So again, it's not a diagnostic measure, but a score of 7 or over suggests that they are more likely to have the traits of reactive attachment disorder. And so for this one, we had 82 children above the cutoff, which was 48% of the sample, which is compared to 62 children who had the diagnosis, were undergoing diagnosis or suspected of having a diagnosis. So again, high numbers, but actually not as high as those who scored above the cutoff for the autistic trait measure, which is interesting. So we move on to the next slide. The other thing I really wanted to do was look at the relationship between the two questionnaire measures I've just put up. So the one that measures autistic traits and attachment disorder traits. And because there's thought to be a lot of behavioural presentation overlap between these two conditions, I wanted to see whether these measures also overlapped, if they correlated with each other. So I examined the correlations between the social communication questionnaire and the relationship problem questionnaire total scores, but I also looked at some of their subscales, which I mentioned earlier on. So overall, there was significant correlation between these two measures. So children who scored high on one were likely to score high on the other. So this suggests that there are these shared behavioural features that was suggested in the previous research. So if we look at the subscales, most of them correlated. So everywhere there's a star, that means they significantly correlated with each other. But the one interesting bit is that the social communication questionnaire, reciprocal social interaction subscale, did not correlate with the relationship problem questionnaire total or the disinhibited attachment subscale. So as a reminder, the reciprocal social interaction is about the quality of back and forth engagement, and the disinhibited behaviors on the attachment styles was around poor social boundaries and impulsivity. And this seems to be where there might be some subtle behavioral differences, especially in my sample. So I think this is something that needs to be looked at more in the future to try and help to distinguish between the autism and the attachment disorder and trauma that seems to have such difficulties with overlap for diagnosis. So if we move on to the next slide, I'm going to talk a little bit about part 3, which was the qualitative interviews. This was an in-depth qualitative understanding of the diagnostic process and support for autistic children and their carers. And this section had 3 main aims. So I wanted to understand foster and kinship carers' experiences of seeking out a diagnosis of autism for children in their care and identify barriers to the diagnostic process. I wanted to explore the support provided to autistic children and their foster carers. And I wanted to identify areas of good practice within the local authorities which could be shared. So if we move on to the next slide, this is the method for this section. So I undertook interviews with foster and kinship carers and social work staff in 3 different local authorities in Wales. So there was a total of 10 interviews with social work staff and 16 interviews with different foster and kinship carers. Some of these foster and kinship care interviews actually included more than one carer, so there were more than 16 participants, but it was 16 different interviews. A key thing to point out at this point is that I did not manage to speak to any children or young people in foster care who were autistic to get their opinions on this. This was something I had set out to do, something I really, really wanted to do, really tried to do, but the logistics of it unfortunately did not work out. There were a lot of problems around identifying appropriate children, young people, and getting appropriate consent as well. So it's just worth bearing in mind when I go through the findings that this is the opinions and the voice of staff and foster and kinship carers, not of young people themselves. And this is a gap I'm hoping to address in future research. So these interviews, were roughly 30 to 60 minutes. They were primarily in person. I did a few of the social work staff ones online, just due to staff preferences and timings. And they focused on the experiences of looking after and working with autistic children, both diagnosed and undiagnosed, focusing on the diagnostic process, support availability, and then relationships and communication. So we move on to the next slide. This identifies some of the key themes. So all of the interview transcripts were transcribed, anonymized, and then analysed, and I used thematic analysis to analyse these. As a result of this analysis, there was 4 key themes that were identified throughout the responses. These are around obtaining an autism diagnosis, support for children and young people, communication and relationships, and then resource availability. So what I'm going to do now is move on and talk about each of these themes in more detail. So on the next slide, the first theme was around obtaining an autism diagnosis. So the thing I heard most about with almost every person I spoke to was around long waiting lists. This is obviously a challenge across the board. It's not just for children who are in care, but it was seen as an extra challenge for those that were in care due to the additional barriers in place for this group. So as this carer said, they've had a rubbish start, they're already slow into these systems, socially they're behind, they're disadvantaged massively already. Can we give them an advantage and do this quick? And we don't need to see they're settled in a placement for 2 years and see if it settles, because if it didn't, we're 2 years behind then again, and that's not fair. There was these additional challenges from being in care. It was also seen as a challenge and further delays if other organisations didn't agree with the decision to seek out a diagnosis. So one that came up quite a lot was disagreements between whether a school and the foster carer both agreed that a child should seek out a diagnosis. There are also difficulties getting a developmental history in some points. So a lot of the diagnostic process does rely on reflecting back to a child when they were younger. And it was discussed with me quite often that it was a challenge filling in some of these forms and knowing what to do because this information just wasn't available to all of the foster carers. One of the local authorities was able to pay for some private diagnoses, which was seen as a positive for some of the people I spoke to. It was especially seen as helpful during the pandemic because these were done online, and especially useful for older children and teenagers who were more willing to engage with this online process, but perhaps less useful for younger children who mostly had no desire to sit in front of a screen and talk to a stranger. To move on to the next slide, there was some further challenges around obtaining an autism diagnosis, and the big one that came up over and over again was the overlaps in presentation of behaviours associated with trauma and autism. So the things I was talking about in the survey section of this presentation. And this was seen as difficult in lots of different ways. So firstly, it was this overlap between the trauma and the autism was seen as difficult to then decide when to seek out a diagnosis because it wasn't always clear whether it should be seeking a neurodevelopmental assessment or whether it was trauma or attachment disorder. So as this member of social work staff said, I don't agree with it, but a lot of the kids that come to our services have got a lot of trauma, a lot of attachment problems. How do you distinguish? I don't know. When do you say, yes, this is a referral to neurodevelopmental assessment team? And when isn't it? So as well as there being a challenge about deciding when to seek out this diagnosis, it was also a challenge when undergoing the assessment itself. So it was seen as difficult to fill out the forms to make it clear about the different behaviours and the different presentations when there was trauma there, as well as potential neurodivergence. And also as a challenge for the clinicians to identify whether this was neurodivergence on top of the trauma. This was a challenge that came up quite a lot in my conversations. And also because of this trauma, it was often suggested the child be left to settle in their placement for a little while to see if the trauma behaviours kind of settled down, so then you could see whether there was something additional on top. But from the foster carers, there was often quite a lot of frustration around a child being left to settle for too long and the wasted time that was mentioned in one of the previous quotes. So we move on to the next slide, we can look at the next theme, which was the support for children and young people. So there was a few examples of good practice here, which were really interesting to consider. So one local authority had an in-house specialist clinical psychologist, and they were able to provide advice and guidance for diagnosis. So like identifying when it was suitable to go for a diagnosis, helping to fill out the forms, get the diagnosis sent to the right place and the right people involved. And they're also able to be involved with support whilst waiting for a diagnosis or after getting a diagnosis. And across the board, this was seen as an incredibly positive experience. Every single foster or kinship carer I spoke to who mentioned this clinical psychologist was saying positive things and what a good experience it was. And the staff was saying the same thing. It was often felt that they didn't know what they'd do without this person. Another local authority was in the process of setting up a specialist autism team to support autistic people and carers across all the different social work teams. This wasn't just focused on children, it was adults as well, so not just looked after, it was across the board. But importantly here, they are only able to offer this support to those with a diagnosis. So if we think about some of the difficulties, especially for children in care to get a diagnosis, this is obviously a limitation in the service. So outside of these two examples of good practice, a lot of the support was often only for children and young people with learning disabilities, and that's where the support was focused. And although some autistic people have learning disabilities, this is not across the board by any means. So there was a lot of children and young people who kind of fell through the gaps and weren't able to get the support they needed. It was often felt as well that you had to be at crisis point to get support, and it wasn't always offered early enough. So as this carer said, it wasn't until we said, look, we genuinely can't cope anymore. We just, we can't be here. Then they started offering more help. And also carers often felt they had to seek out their own help and support in the community because there wasn't anything offered to them elsewhere. And this was seen as easier for more experienced foster carers with bigger networks who understood more was out there, and more of a challenge for some of the newer foster carers. So we move on to the next slide. Um, there was also a lot of conversations about support offered in school, and the conversations around this varied greatly. There were some really positive experience and some less positive experiences. So a positive relationship with school and the support offered by the school was often associated with good attendance and the child making really good progress and being settled in school. Sometimes carers told me they had to change schools to get the appropriate support for their child and young person to be able to get this positive relationship up and going. And others told me that they just felt frustrated with the support offered through school and that it wasn't enough. So this carer said, I've been fighting for this child for the last 3 years because I believe they have an entitlement like any other child to be educated and live a perfectly normal life. And they're not getting that. They're not. They're failed. Every step of the way, they're failed, you know? There was all these mixed experiences with schools. Also, as I briefly mentioned earlier on, a lot of carers felt that a diagnosis was seen as the gateway to support, but some carers who had got a diagnosis for the child they were looking after then afterwards didn't get this support. So it wasn't always the case, which was a challenge. So if we move on to the next slide, this is the next theme. So this is communication and relationships. So a positive carer-social worker relationship and feeling listened to really improve the support for both the carer and the child. And this positive relationship and this feeling important and listened to was seen as key for ensuring this good communication moving forwards. And social workers also told me about the importance of trusting foster and kinship carers. So as this member of social work staff said, I think in my opinion, if I had foster carers that were say, you know, I'm seeing really strong traits, then I would be bringing that up in reviews or with the childcare worker that this possibly needs an assessment. I would be going with that really because they do have training in attachment and trauma as well. So this highlights the importance of the foster carer being treated as a professional with knowledge and expertise. If we move on to the next slide, we can see that this communication and relationship wasn't always so positive. So some carers felt undervalued and that their opinion was not important, which really affected the relationship. So as this carer said, they don't live with it 24/7 like we do. And I think nobody knows these children more than the foster carers that live with them, and they need to listen to us more. You know, I find that frustrating. So this highlights kind of how the relationship could go downhill if they don't feel that this communication and trust is there. Inconsistency of social workers is something that came up a fair bit, and this was seen as a real challenge to the communication and relationships. So social workers having to change their caseloads, moving to a different team or leaving the organisation entirely was a big challenge, and then these relationships had to start up again with a new person. Challenging relationships with schools could be really difficult to navigate, which I talked quite a lot about in the previous theme around support. And sadly, sometimes poor communication could result in placement breakdowns. And I heard a couple of sad stories around this, where this relationship had broken down so much that the placement had to end and the child had to move to another placement. So move on to the next slide and the final theme of resource availability. So the main resource that came up over and over again was around financial constraints. And these were such a big challenge that just kept coming up. So, for example, for some, accessing a private diagnosis was seen as really beneficial, but there wasn't always the money available to do this, which was seen as a big constraint. And the normal diagnostic process that children had to wait for was obviously such a long waiting list. This was seen as a really big problem. And this carer said about the diagnostic process, there obviously needs to be a heck of a lot more funding there because they obviously don't have enough funding to hire enough people to do it. So it was felt that more money and more staff would really improve this diagnostic process. Limitations in school support came up a lot, whether this was due to financial constraints or the way that the school did the support, but this was seen as a real challenge. When discussing training, there was lots of training discussed about trauma, quite a lot about neurodivergence, but then less or none in most cases on the overlap between trauma and neurodivergence, and also very little on the actual diagnostic process. So for example, one carer really wanted to support a young person they were looking after through the diagnostic process and tell them what would happen, but they didn't know themselves, so this was a challenge for them. It was also felt that more support groups could be beneficial, both for the foster carers and for the children and young people. whether it's in the community or elsewhere, it was felt that this would be a really helpful resource. So if we move on to the next slide, just a few conclusions to try and pull together some of the threads from the 3 different parts of this project. So overall, there were higher numbers of children in care who have a diagnosis of autism compared to those not in care. But on top of this, even higher numbers have those high levels of autistic traits, so daily behaviours and difficulties in their lives. More care experienced autistic people might be getting their diagnosis as adults, which has important knock-on effects when we think about support when you're younger and the importance of that. Distinguishing between attachment disorder or trauma and autism seems to make diagnosis even more complicated, and the overlaps seen and discussed about these throughout the different strands of this project. Gaining an appropriate diagnosis and support for children in care is a real challenge due to lots of different reasons that I just went through. But communication and good relationships can really help to support both the diagnostic side of things and the support availability for both the children and for their carers. To move on to the next slide, I was just going to talk a little bit about what I'm doing next to follow up on some of this. So obviously this has raised lots of important issues, it's highlighted lots of things, but there's also lots of things that need to be followed up on and understood more about. So I'm currently in the process of developing the next research projects for this. And one of the key things I'm doing is I'm talking to those who are the key stakeholders in this research to really help them to inform where the priorities should be. So speaking to care experienced young people, foster and kinship carers, adults with previous social care experience, and social workers and independent fostering agencies. I've had lots of really good conversations with all of these. If we move on to the next slide, we can see that a lot of my conversations look a lot like this, where everything seems to be a priority for everybody, which is obviously very valid. These are all very important issues. If we move on to the next slide, you can see I've kind of started to pull out some of the key research priorities in this area and areas that I'm trying to develop. So I think some of the key areas to focus in on are around these diagnosis challenges that I've talked a lot about in this talk. The support needs of neurodivergent children in care. So this is looking at those that are diagnosed and undiagnosed due to the difficulties with diagnosis. Transitions to adulthood for neurodivergent care experience young people comes up quite a lot. So obviously transitions are a challenge for anyone, but an additional challenge for a lot of people with neurodivergence. Support and training needs for professionals around a lot of these issues that I'm talking about, and also around supporting neurodivergent families at home. So if we move on to the final slide, I just wanted to say thank you very much for listening. I'm happy to answer questions now. I'm also happy for anyone to contact me via email if they have any questions they think of later or would rather share in that way. Or if you wanted to be involved in shaping of any of the future research, please feel free to get in touch. I'm always very happy to talk to anyone who's interested. And thank you very much for listening.
Wonderful. Thank you so much, Sarah. That was a really interesting presentation and absolutely jam-packed with info and findings. You've clearly been really, really busy over the past 3 years. So as Sarah said, she's happy to take any questions or sort of contact from people outside of this webinar. And she's also really kindly agreed to share her slides with everyone, as Sean mentioned in the chat there. So you will be receiving Sarah's slides in about a week's time over email. We've got a few questions here in the chat already that I'm going to do my best to kind of get through as many of those as we can in the next sort of 12 minutes or so. Do pop any questions in the chat as well, and we'll try and get through as many as we can. So I'm going to start off with the first question. Somebody said that they're kind of surprised that there's only 3% of children that are being diagnosed with autism, considering the recent increases in knowledge and awareness around autism. And so I'm going to combine that with another question, someone who's asked about the data source. So I wonder, Sarah, whether you can kind of reflect on that question about the percentage of children being diagnosed and whether that's got anything to do with the years from which the data's come from in SAIL, and what the source is, whether it's GP data or anything like that. That can kind of provide a bit of insight, and whether you would expect that to increase when we get data for more recent years.
Yeah, so the numbers were if I remember rightly, were 3% for those without care experience and then 7% for those with care experience. Obviously, yes, numbers are increasing. So if you look back at research from 20 years ago, they'd very happily tell you that 1% of the population are autistic. So even the 3% number has increased up from that. Yeah, the data is anyone who has a marker for being diagnosed as autistic in the SAIL data bank, and it's primarily from GP data. But we did cross with, I think, hospital data and one other. I'm sorry, I don't know entirely off the top of my head. So there will be probably higher numbers than that. Like, the SAIL data bank is not perfect. It's a great resource, but there will be some children that the data has just not been recorded appropriately. So I would say that 3 and 7% are both a slight underrepresentation, but I think a lot of it's the importance between those numbers. So the fact that one is just over double, the other one is kind of the significant bit, even if they're slightly lower. And yeah, I think diagnoses are increasing over time as we've become more awareness. A lot of that is adults being diagnosed, though that obviously wouldn't be captured in my data. But yeah, I think it is increasing. And if you look back at papers, like I say, they all say very confidently that 1% of the population are autistic, which is clearly not the case.
Thanks, Sarah. Yeah, that's really interesting. Obviously, there are still numbers of people that aren't diagnosed that we don't know about in that statistical administrative data that you've got access to. Somebody's asked about sort of the being mindful about differences in the types of assessments offered, and there's not always equal access to services. And I was wondering whether you were able to do any kind of further analysis into looking at differences between local authorities, or whether you were able to break the data down by any other kind of demographic factors at all.
So for the SAIL data, no, I wasn't allowed to have access to local authority level data because they obviously try and keep all the data secure and anonymized. So I was only access to population level data. So yeah, basically, unfortunately, unable to break that one down any further.
Okay, thank you. And somebody's asked how anxiety and depression was determined in the data. Was it diagnosed by a clinician or determined by the participant themselves? If the latter, was the language used in the survey or interview assessed for its accessibility, etc.?
So in the SAIL data, it was diagnosed levels of anxiety and depression. So it would have been diagnosed through GP or hospital data. Basically, if they ever had a marker for a diagnosis of anxiety or depression, it showed as a positive result. I also asked about levels of anxiety and depression in my survey, which I didn't present as much, but that was again asked on diagnostic. So because I didn't speak to any children, young people themselves, unfortunately, I wasn't able to assess their own self-identification. So that's just something that wasn't possible in this, but hopefully future research, there will be a lot more self-identification things happening.
Lovely, thank you. And we've got quite a few questions actually from the same person, so you've definitely got one person really interested and got them thinking. So they have asked, did any of the carers or indeed social care workers have a diagnosis of autism themselves? And if so, did they think this gave them a better understanding of the young people in their care and the challenges they face, particularly in their situation?
Yeah, so it's a really interesting question. It's not something I went in asking about because I was focusing on specifically the experiences of the children. So this would have just been whether anyone self-identified through the conversation. And there was a member of social work staff I spoke to who self-identified as autistic. And we had some great conversations around how that she felt that kind of influenced how she worked with it. And obviously it really impacted her passion. I think it's likely that some of the foster carers, just because of the number I spoke to, may well have a diagnosis or be some sort of neurodivergence, but it's not a conversation that come up and anyone self-identified for it. But it would be an interesting thing to think about.
Sure. And is there, did any carers feel overwhelmed with the additional challenges of caring for children with autism and have to, unfortunately, give up their role as they didn't feel like they were receiving adequate support?
Yeah, I think overwhelmed is definitely something that came up a lot in these conversations. A large amount of the carers I spoke to were caring for children who were suspected to be autistic but didn't have a diagnosis due to a lot of those challenges that I've talked about. And there was a lot of frustration around a lack of support or a lack of help trying to get a diagnosis or support through school and all of that. And I said briefly on one of them that a couple of cases did lead to placement breakdown. So the carers were so overwhelmed with the situations they were in, felt they didn't know what to do best for the child, didn't know how to handle the situation. And it did sadly result in a placement breakdown. I did also speak to one carer who was leaving foster care as a result, not necessarily of the children, but the difficulty she felt in the system caring for these children with additional needs. So definitely overwhelmed. I also have data from the survey. I did the parental stress scale, which I mentioned briefly. I didn't have time to talk about. It's one thing I haven't had a chance to analyze yet, but I feel that that is likely to show a similar pattern.
Wow. Yeah, you certainly have done much more work than you could possibly pack into a 40-minute webinar. So that's really interesting. If anyone wants to know more about that, I'm sure Sarah won't mind you pinging us some questions over email. One person has asked quite an interesting question here about the hierarchy of diagnosis, about whether children diagnosed through the NHS are given more support as the diagnosing body is perceived to be a more trustworthy source. I assume this is in comparison to kind of private providers of autism diagnosis. Be interesting to know your thoughts on that, or whether you have that information at all.
Yeah, so not something I asked about, but definitely something that I've heard about from other sources and comes up. And yet, in general, getting an NHS diagnosis is seen as a lot more valid, especially for school support. They won't necessarily always accept a private diagnosis because the diagnostic assessments can be less rigid. I'm not saying they are, sometimes they're more rigid, but there's a lot more control over the assessments that have to be used in the NHS, and they have to always do it the same way, so it's seen as more consistent, whereas private don't have that level of oversight. I think it's unfortunate because so many people are having to get private diagnoses due to like extremely long waiting lists. I have adult friends who paid for a private diagnosis because they were told it would be 7 years for them to see someone on the NHS. So yes, unfortunately, that is still a thing. I think there's getting more acceptance for private diagnosis gradually, but not universally.
Yeah, really big challenge, isn't it? I think that's all the questions we've got in the chat. Hopefully, I've covered everything well enough for everyone that wanted to ask something there. I have a quick question myself, if you don't mind answering for me, or whether you can answer, I don't know. Is kind of, you mentioned about attachment disorder and autism being very similar presentations. And I was just wondering kind of what the difference in how you would support children with those two different conditions are, and actually whether there's benefits to supporting a child as if they have autism, but they've got attachment disorder. Is it still helpful, or is it not helpful? Are there any negative impacts of that?
Yeah, so there might be people here that know more than me fully on that one. I know a little bit. But I mean, in general, there's a lot there for trying to support the needs of a child rather than supporting the diagnosis of a child. And this is a lot of kind of what I'm trying to move into. So if a child is showing something that's part of autism, if they don't have a diagnosis of autism, we can support that need. If they're having a challenge around sensory difficulties, it kind of doesn't matter in a lot of ways what's causing that challenge. We need to support that sensory preferences to kind of make them more comfortable, less anxious, and so that they can process things. I think the challenges often come that supporting attachment disorder kind of has a toolkit, a way of doing it. And there's bits of that that necessarily don't always support neurodivergence. So moving towards supporting the individual needs of a child would be hugely beneficial, rather than just assuming, but also supports for neurodivergence can be very beneficial for other people. So it is very intertwined. There's no real clear-cut answer, but supporting the needs of the child, I think, is something that's very important that we need to consider moving forward. And Welsh Government has a lot of focus around like the needs-based approach rather than diagnostic-based approach. But unfortunately, diagnoses are still seen as really important for other things, for support, for protections, for other things, which is why there's a bit of a conflict around how best to deal with these issues at the moment.
Brilliant, thanks, Sarah. And Gail Gerard has just mentioned that there is some guidance around good practice on assessing multiple facets. So you will see that there's just a little poll that's popped up here for you to answer, just to help us improve the presentations and things that we're delivering through ExChange. We'd be really grateful if you just fill in that poll quickly now. And as you're doing that, just a final thought from you, Sarah. I'd love to know what it is that you're most looking forward to about the next stage of your research.
I mean, quite a lot of it, but I think the main thing standing out for me is finally getting a young person voice in the research. So I've had a young person voice in the public involvement work I've been doing, and a lot of people with relevant experience that are passionate about the project, that hopefully we can then get involved in the research in a way to ensure that all voices are covered.
Fantastic. Yeah, really exciting. Really looking forward to hearing what you come with next to talk about. I think it's a really important area of research, and thank you so much for taking the time to answer all the questions and give us such a fantastic presentation today. And thanks everyone for attending. And it's now 1 o'clock. So that's all from us. Many thanks. See you all soon.